Good morning. Maayong aga sa tanan. So I will share our practice as a respiratory therapist in our institution in sa Biligan Memorial General Hospital. So my objectives, to set tasks for respiratory procedures and treatment that are proven to lead to optimal efficiency and result, to ensure our staff must educate patient regarding respiratory care treatment procedure, to produce optimal results, increase efficiency, and develop respiratory care plans and procedures. So, I don't have disclosure. I am from Aklan, and I am here in Iloilo. Masadsad kita tanan. Wala tayong issue sa sadsad. So, brief history of JBL-MGH is a level 3 tertiary teaching and training hospital with 250 approved bed capacity under RA 6780/1990, and in 2023 with a total of 850 bed capacity, and in 2025 target for 1,000 bed capacity. The hospital serves for the population of Region 3 with Pampanga as its primary catchment area and the provinces of Bataan, Nueva Ecija, Bulacan, Tarlac, Zambales, and Aurora as secondary region. So, being a respiratory therapist, it's very important to perform patient assessment, diagnosis, and treatment to patients who are difficulty of breathing. Respiratory therapists are trained and experienced in order to come up with treatment plans which best help patients regain their ability to breathe normally. In combination with doctors and collaboration of doctors and nurses, they work with people of all ages from infants to old ages. So as a respiratory therapist, my goal, your goal, and our goal is to promote quality pulmonary care. So RT should and must have comprehensive patient assessment. So in performing comprehensive patient assessment, to have thorough assessment of patient in relation to pulmonary health, the RT must do this following. We must get the ideal body weight. So, sino po sa inyo dito na kinukuha ang ideal body weight in your monitoring? Okay.
Wala. Kumukuha naman tayo.
Chest X-ray interpretation. Meron po ba may institution na nag-interpret ng chest X-ray? Checking laboratory results in relation with respiratory care management. Bukod sa ABG, meron din po tayo dito check. So, vital signs and GCS, chinecheck din ba natin? Familiarize with inotropes and sedation. So, sa books lang natin ito nakikita. So, mas maganda as an RT, lahat yan na experience at saka ginagawa natin. So in JBL-MGH, we are focused in critical care area only. So our ICU, including ER, total of 140 bed capacity. ICU lang yan. Hindi kami nag-focus sa general care. So it's very important to get the ideal body weight. So it's calculated based on the gender and height of the patient to ensure the weight used to estimate tidal volume is correct based on what the patient should receive. So yan, required sa amin na kinukuha yung ideal body weight. So mini-measure namin using the measuring tape. So bago namin ginagawa yan, nagpapaalam muna kami kasi baka isipin na ng relative, buhay pa yung pasyente, sinusukatan na namin. So, importante kinukuha kasi ang practice kasi ng karamihan standard na yung tidal volume na binibigay. So, mas maganda kung kinukuha natin yung ideal value weight para sa initiation of mechanical ventilation. So, this is our shortcut method to get the ideal body weight. In male, height in cm minus 100 times 0.94. Ideal body weight in female, minus 100 times 0.88. So our initial settings, we start with 7 to 8 meals per kg, but some books 8 to 10 and 10 to 12. We start with 7 to 8 after hooking in mechanical ventilation, and we also base kung meron pa kaming need na adjustment sa chest x-ray and laboratory. So from 7 to 8, we still have space to increase our tidal volume. So in our institution, we do chest x-ray interpretation. So hindi naman natin kailangan na maging radiologist para ma-interpret ng chest x-ray. So as an RD, basic lang ang interpretation na tinuturo ko sa mga kasamaan ko. So we start with the ABCD. So ano ba yung A? Airway. So check mo yung airway natin. Kung 3 to 5 cm above karay na ba ang ETP level sa adult. In pedia, 1 to 2 cm. Then check for the tracheal deviation. B, look for the bones comprising your lungs. So it's kailangan lang 8 to 9 para sa intubated patient para malaman natin kung hyperinflated ba yung patient natin. Kung meron pa tayong space para increase ng tidal volume and rate. Next, for the D, check for the diaphragm and heart size. So after nun, ma-check namin, we go for the interpretation. Infiltrates, consolidation, congestion, cardiomegaly, and pneumothorax, and pleural effusion and RDS. So in chest x-ray interpretation, so most commonly kasi nangyayari, nagkaroon ng right main-step intubation kasi ang right bronchus natin is shorter and wider. So, compare mo sa dalawang x-ray, yung isa naka-flex yung chin, yung isa naman hyperextended. So in reading of chest x-ray, it's very important to check also yung chin natin, kung paano siya kinuha yung x-ray. So, as an RT, anong pakialam ko ba sa laboratory? So, as an RT, it's very important. So, dino-document din namin to check the laboratory result, especially the WBC. So, we'll check if there's a presence of infection, RBC and hemoglobin, especially in dealing with mechanical ventilation management. Naka-high settings ka na, high FiO2, then desaturation pa na ba yung patient mo, then check. Bagsak pa na hemoglobin, so need for blood transfusion. So, sodium and potassium, especially if the patient is foreweaning, we check for the potassium level because that is responsible for the muscle. Urea, urea if the patient has CKD. Platelets, it's very important to monitor the blood clotting, the PT, PTT, and INR. Kasi kung meron tayong procedure sa patient, maging cautious tayo, especially if we are performing invasive procedure like insertion of nasopharyngeal airway and ABG. So, pag mataas mo yan, pag mababa, so may malaman natin kung bleeder yung patient. So as an RT, ano bang pakialam ko sa fluid balance? Especially yung patient with mechanical ventilation. Kasi pang nurse lang yan. So malaking factor as an RT to monitor also the fluid balance. So kailangan ang intubated patient to maintain the negative balance. So ano ba nangyayari pag positive balance ang patient in intubated? If there's a presence of excess of fluid in the lungs, so nagkakaroon ng increase in extravascular fluid, so nangyayari decrease in oxygen content, decrease of increased work of breathing, then increased consumption of oxygen in the respiratory muscle. So kailangan natin ma-monitor. So, kailangan mo lang magtaas ng PEEP to push the extravascular fluid. So ABG, lahat alam naman natin yan. So as a former infection control in San Juan de Dios, I adapted the design for our ABG packs. So may purpose po yan to prevent needle prick injury. So, tutusok mo dyan, pag mag-ABG ka, dahil ibabalik mo doon. So parang iniiwas na namin yung needle prick injury. So it's very important to monitor vital signs and GCS level as a respiratory therapist. Most commonly practice kasi sa atin, I don't know how to call that, parang nangyayari ang practice is parang drive-thru. Pagkatapos mo mahiyog yung patient, nakuha yung order, aalis ka na. But still, it's very important to perform patient assessment. So, pinomonitor din namin yung GCS level ng patient. So, in adult, kinocompute namin, but in neonatal na intubated, we also identify lang na kung wake or awake yung patient. So sa RT, in our institution, we always monitor if the patient have inotropes and sedation. So most commonly used inotropes, norepinephrine, epinephrine, dobutamine, and dopamine. So in some acute stroke unit, hypertensive patient, most common ko nakikita is dicardipine. So, as an RT, we must know and familiarize and assess the patient if have present on sedation, diazepam most commonly, midazolam, propofol, and fentanyl. Ang patient mo, example, nagto-troubleshoot ka ng patient, hindi nagsisynchronize yung ventilation, adjust ka ng adjust. So, hindi mo siya mapagsabay yung breathing ng patient and the mechanical ventilator. So, ano yung problema? So, kailangan assessment. So, check mo if the patient on sedation. Kasi kung wala naman siyang sedation, hindi mo siya makakorek. Then, assessment. Usually, yun ang tinuturo ko sa mga kasama ko. Use your critical thinking and assessment. Especially kung hindi naman siya sedated, then yung problem natin is central. Especially mga neuro patient. So, hindi mo makakontrol yan. The most common use paralytic drugs. So usually ginagamit to sa patient on high frequency oscillation ventilation. So respiratory assessment. So ito ang routine namin ginagamit. So meron tayong mga intern, nagro-rotate na kayo. Do you do or perform auscultation? Raise your hand. Hindi. So, hindi kayo nag-auscultate. Meron. Sige nga. Identify mo yung mga abnormal breath sounds. So, it's very important. Ito yung usual common na routine namin ginagawa. Breath sounds, assessment ng secretion, kung via nasotracheal, endotracheal, or cough. In our treatment, we do also patient assessment and ventilator monitoring. So it's very important as an RT to perform auscultation. Kasi dyan yung basic mo na paano mo i-manage yung patient. So, aminin natin, maraming hospital na hindi ginagawa yan. So, paano natin ma-assess yung patient? Tapos sa board exam, ang dami kailangang basahin. Pero, hindi naman siya na-apply. Para kasing, pag gumamit tayo ng stethoscope, parang iniisip kasi natin na pang doktor lang siya. Pero sa RT, gamitin nyo makakatulong yan kung paano nyo i-manage yung patient. So this is of the breath sounds. So yung bago sa akin dyan, yung squawk. Bali, para siyang tunog ng gansa. So mostly kasi ang wheezes is expiratory. Si squawk ay inspiratory wheezes with crackles. Then in patient naman na ANCAF, like neonatal and pediatric ANCAF, so in not known case of asthma, pero pag pinascoltate natin, para may wheezes din, ang ina-identify namin yan as transmitted sound. So secretion, lahat ba kayo? Sino nagsasuction sa hospital? Hindi kayo gumagawa. Nurse. So kami, in our assessment, sinasama namin ang secretion. So dyan kasi namin ma-assess kung ang patient is candidate for extubation, kung meron siyang presence of cough and gag reflex. So, this is the procedure how to perform suctioning. So, PRN lang naman siya. So, pero dito, normal saline instillation is hindi siya routine, pero mostly nag-instill talaga kami ng saline. So, in our institution, all ICU using closed suction system. So, naka-closed suction lahat ng patient. Salamat kay COVID kasi nung nagka-COVID, dyan nakilala si closed suction. So, automatic lahat ng patient naka-closed suction. So, based dyan sa patient assessment namin, ina-assess namin yung secretion. Example, pag small, S, moderate, M, large is L. So ano siya? Thin or thick. Then identify mo ano siya? Mucoid 1, purulent 2, yellowish 3, greenish 4, rusty 5, fruity 6. So pag in-assess na namin ang example, moderate M, thick, TK, and 3 yellowish. So magiging MTK3, so meron siyang moderate thick yellowish secretion. So we always perform auscultation. So ano siya? Inspiratory or expiratory. So maglalagay lang kami ng number. Example, 1 is for clear, 2 for fine crackles, 3 for coarse crackles, 4 in wheezes, etc. So in respiratory care assessment, all treatment performing respiratory modalities, we perform patient assessment. So, yan sinasabi ko lahat ng procedure namin. Meron kaming pre- and post-assessment. Kasama sa procedure, mechanical percussor, performing chest physiotherapy. So, we have high-frequency chest wall oscillation. So, yan yung may vest siya. Tapos, i-inflate mo parang, meron kayo dito niyan. So, meron din sa St. Luke's Global, nung nagkataon ako seminar, lung center.
Bus lang yan.
So, papasok mo yung vest, tapos pipili ko kayo ng frequency, isi-set mo. So, as per study pa rin, so usually ginagamit lang sa mga intubated patient na prolonged bed rest. So, pero as per study pa rin, the best tumubal execution pa rin is ambulation. So, this is an example of our respiratory treatment flow sheet. So, meron kaming assessment. Naalala ko dati, I'm working in previous hospital. Ano lang, lagay mo lang, treatment done, not done. Awake. Awake. Feeding. So kami, we do the patient assessment. So first, if you're doing the SPN or small volume nebulizer, you will get first the heart rate, saturation, and the RR. Then, auscultate. May presence ba siya ng wheezes? Then, identify ko na yung breath sounds mo. Then, after, give the treatment. After the treatment, assess ulit. Kung meron pang pagbabago. So, syempre, sino nagbibigay? Di ba lahat? Usually, nagbibigay ng nebulization. So, paano nyo na-assess kung effective ang treatment nyo kung hindi kayo nag-auscultate? Then, merong mga uso pa na back-to-back, 30 minutes.
Dito sa Pilipinas.
So, paano mo ma-assess yung patient na kailangan mo i-continue yung treatment? Di ba? By the book. Kailangan ko yan sa sugar trade.
Pagra-rounds mo.
Yung baseline mo, pag tumaas siya ng 10 to 15, kailangan stop mo na yung treatment. So, paano mo ma-assess yan? Kung bigay lang kayo ng bigay ng treatment na wala namang assessment. Nakailang dose ka na, wheezes pa rin. So dapat, tapos tachycardic na, tuloy-tuloy pa rin. So paano na-assess kung wala naman kayong assessment? So it's very important to perform patient assessment. So this is our non-invasive ventilator. So we will do assessment. So automatic pag ganyan, bago namin i-intubate, try muna namin to hook sa non-invasive. Neonatal, we have the bubble CPAP. So ventilator and patient monitoring is a must. So share ko kung ano yung monitoring namin. So sometimes we do bedside endorsement. So dyan na magkakaalaman kung yung RT mo ba ay alam yung pasyente niya, kilala yung pasyente niya, or nagka-copy-paste lang ng sinusulat. So sometimes, doon mo mahuhuli kung alam nga ba na ni RT yung case ng patient niya. So nagre-receive ako ng bedside endorsement. So, usually naman lahat ng equipment is consumables are disposable. So we have cap pressure manometer to measure the cap pressure. So kasama yan sa ventilator monitoring namin. So it's very important also sa neonatal, especially do bagging, nakakapit dapat ang cap pressure manometer para ma-monitor mo na hindi nag-exceed sa 22 cm per water ang pressure na binibigay. We use ETT holder, measuring tape to measure the ideal body weight. So this is the sample of our ventilator monitoring. So first, patient information. Then kung kailan siya na-admit sa ICU. Kailan siya na-intubate. ATT size. We do monitor also the ATT level. So para every monitoring mo, alam mo kung nagbago ang ATT level niya. And we also monitor how many total days the patient on mechanical ventilator. Then, at bedside, we always check if there's our ambu bag o backpack mask sa patient mismo. Kasi in case of emergency, kailangan nandun lang siya na makukuha mo agad. Then, days ng change ng circuit, diagnosis, and history of the patient. It's very important to know the history of patient. Then, ventilator mode, then yung picture ng lungs, dyan mo ilalagay yung number ng auscultation mo. Kung 1, 2, 3, so by number lang. So dyan yung auscultation mo. So our ventilator monitoring every 4 hours. Then, sa likod, kami gumagawa ng patient plan. So example, dun sa pinakataas, yung order ng doctor, window extubate. So ilalagay, i-check lang namin. So lahat nakalagay na doon. Then, in our patient assessment, we do RT notes. So name ang initial ng RT, time kung anong oras mo ginawa yung patient assessment. Then, i-check mo lahat kung meron ba siyang inotropes, sedation, fluid balance, then check mo din yung sore niya ng lip kung okay pa ba. Then yung picture ng lungs na yan yung chest x-ray interpretation namin. Kung anong date, ilang level above the carina. So the RT notes, yung blank space na yan. So merong nurses note, kami meron ding RT notes. Example, 8 a.m. patient receive on CMB, increase FiO2 due to desaturation. So naglalagay kami kung ano, every event ng patient. Example, for CPAP siya, PSP ng 10. So malalagay ulit kami, 10 a.m. Patient shift to PSP and CPAP. Vital signs, normal, with acceptable parameters. So every time, naglalagay kami ng RT notes kung merong nangyayari sa patient. So for those who are in ventilator support, when is weaning possible? So in our institution, kami ang nag-extubate ng patient. So doctor's order, i-assess namin yung patient kung fit for extubation. So in performing weaning, use always your critical thinking and your comprehensive patient assessment. So weaning criteria, so kami kasi yung nag-extubate na. So the 3 key points have evolved as criteria for weaning. So identify the root cause for ventilator support. The problem that caused the patient to require ventilation must have been resolved. So before merong patient nung COVID, siyempre pag nahihirapan huminga, automatic intubate, then isolation, lalabas lang pag yung results ng COVID. So hindi siya masyadong na-assess. So nung nakalabas na siya sa COVID area, in-assess ko yung patient, dinala ko yung dalawang kasamahan, sabi ko, i-assess nyo kung yung patient is fit for extubation. So kami lang. So sabi ng dalawa, hindi sir pwedeng ma-extubate kasi may wheezes siya, ganyan. Okay, tanong ko din isa, hindi din daw pwede. Sabi ko, kung ang problem natin ay wheezes lang, bakit kailangan natin hindi siya extubate? So anong treatment dapat ang ibigay kung may wheezes? Then after that, so after namin discuss, we proceed to extubation, kami lang. And then after, we give back-to-back nebulization. Salbutamol. So, na-win namin yung na-extubate namin yung patient. Then, check the spontaneous breathing trial, measurement of readiness. So, it's very important to familiarize and know the weaning criteria. So, sa weaning criteria sa ABG, kailangan maging normal. Next, pag patient mo naman is metabolic acidosis, pag hindi pa nako-correct, so kailangan mo rin i-support through mechanical ventilation to hyperventilate the patient to correct the metabolic acidosis. Then, patient with alkalosis, mechanically hyperventilated for several days may have been reduced ventilatory rate. So what are your predictors in weaning criteria? It's very important to assess, to check patient readiness for extubation. If the patient passes these predictors, he or she has high chance for successful extubation. So ito ang mga chinecheck natin. So lahat, alam na yan. RSBI. So pag more than 105, winning is failure. Less than 105, winning is success. So how we check also the NIF or MIF, negative inspiratory force. So sino nag-perform ng MIF or NIF during extubation? So punta ka sa ventilator, punta ka sa procedure, then punta ka ng merong procedure doon, then instruct the patient to inhale, then i-occlude mo yun, so lalabas, yan ang magiging result na for 10 seconds, breath hold mo, so yun ang lalabas na NIF and or maximum inspiratory pressure. Then the other one is the PO1, the pressure occlusion. So ganoon din, ano lang din siya, tapos kailangan ang result mo is more than -2. So yun ang kailangan i-check natin yung respiratory muscles ng patient pag fit na siya for extubation. So cuff link test, it's very important, especially mga long-term patient na intubated. So dito lang ako, so dito ko lang nakita na may mga patient na umaabot na ng ilang buwan, naka-intubate pa rin, naka-endotracheal tube. So practice kasi namin abroad, maximum 10 to 14 days with twice failure extubation, automatic kasi ititrate na yung patient. So dito lang nakikita, medyo matagal na ADT. So very important to check the cuff link test. Kasi kung bagsak yung cuff link test mo, baka kailangan mo magbigay ng Imsol therapy. So the patient is ready for extubation. What do you do? So since kami ang gumagawa ng extubation, so ito yung ginagawa namin sa patient. So pag may order na, sa criteria namin pasok, so sinasabihan na namin yung nursing attendant na NPO na yung patient kasi for extubation. Pero once ang patient hindi siya fit for extubation, with order na for extubation, as per assessment ni RT na hindi siya fit for extubation, hindi namin ginagawa yung extubation. So explain to the doctor, bagsak sa extubation criteria. So as a respiratory therapist, this is my motto: successful winning is my winning. So other practices to help prevent complication to the patient. So cleaning of ventilators. So we have a protocol. Kahit yung patient mo is nakahook sa, kahit yung patient, ventilator mo nakahook sa patient, we do every shift cleaning. So we're using Big-One-It and Discosep. So pag daily cleaning lang, Big-One-It lang ginagamit namin. Pag discharge sa patient, yung Discosep and Big-One-It. So dinadilute lang siya sa water. So we have a respiratory therapy assistant who are assigned for cleaning and other tasks. So ang respiratory assistant namin, yan yung mga non-licensed RT. So, ginawa ko ng job description, exemptions na ginagawa nila is hindi sila pwede mag-perform ng invasive procedure. So, ito yung protocol namin. Every 2 weeks for neonatal and pediatric circuit, 1 month pa rin sa adult. So, sa bacterial filter, usually, every shift na namin pinapalitan. HME protocol, every 72 hours. Then, after 72 hours, shift to active humidifier. But if the patient have maraming secretion, so initial agad, shift to active humidifier. Close action, every 7 days. So this is our mga kasama ko sa bilingan. So nag-create ako ng meron kaming monthly education program. So ang lahat ng staff, hindi intern na magpe-present, kundi staff magpe-present ng lecture, case presentation. So para ma-refresh kami every month kung ano yung mga latest. Kasi pag routine, basic yung ginagawa, minsan nakakalimutan natin. So nag-iisip ako ng mga topic para magkaroon kami ng monthly education program and case presentation. And I have also, in collaboration with infection control, nagle-lecture din ako sa mga bagong nurses, doctor, how to perform airway suctioning. So tinuturuan namin sila, doctor, nurses, proper perform closed suction system, nasopharyngeal tracheal suctioning, oropharyngeal suctioning, mucus trap for sputum GS. So kami na gumagawa niya. So mucus trap for sputum GS. So mahigpit ang infection control sa amin. So masyadong mataas ang target namin para sa ventilator-associated pneumonia. So this February we have 0 cases of BAP. So infection control begins with awareness and action. So breath, live, and believe. Once a respiratory therapy strikes, a life survives. Parang based sa presentation ko, lahat tayo nandito, ano pa sa tingin nyo ang kailangan natin idagdag sa ginagawa natin? Kasi kung routine lang na hook, alis, saksak ka ng nebulizer, alis. So, kahit sino pwedeng gawin yun. So, paano na, ang goal kasi natin, paano natin makuha ang respect at trust ng doktor. So, once makuha natin yan, tutulungan din naman tayo ng mga yan. So, ang tanong ko, based sa present ko, ano pa ang pwede natin idagdag doon? Kasi, working abroad as a respiratory therapist, gamit na gamit kami doon. Nagagawa namin lahat kung ano talaga sa book. Bakit dito, sa lugar natin, hindi natin siya na-apply? Yun lang. Research it. Sige, thank you.
Well, thank you, Sir Jorge, for that very informative lecture. Ang dami natin natutunan dun, no? Nakakaingit. Kasi madami yung mga hindi nagagawa sa amin. Sige, so, to award the Certificate of Recognition to Mr. Michael Jorge R. Falencio, RTRP, let's call Ma'am Michelle Martha Alejandria Hill. So this Certificate of Recognition reads, for his phenomenal insights and well-thought-out presentation of the topic Best Practices in Respiratory Care Department, the JBL Experience, during the first Summer Conference and 6th Regional Assembly given this 21st day of March 2024, held at Punta Villa Resort Incorporated, Iloilo City.